This is the Transition Series Topics to the EMT, Topic 12, Issues in Airway Management, Oxygenation, and Ventilation. Our objectives for this topic are to review pathophysiologic changes that occur with upper and lower airway dysfunction, differentiate respiratory distress from respiratory failure, and discuss current treatment guidelines for oxygenating and ventilating patients. Failure to oxygenate a patient will doom all other interventions to failure. Without adequate cellular oxygenation, all other interventions, however heroic, will fail. Assessment and treatment of respiratory distress and failure is a fundamental EMT skill. It requires constant practice, particularly practicing auscultation. Immediate identification of and action for respiratory issues is more important than the eventual differential diagnosis. Air exchange and oxygenation trump all other concerns. Shortness of breath is the most common EMS call. According to the Centers for Disease Control and Prevention, respiratory distress accounts for roughly 2% of all emergency department visits. But as EMTs, we see a significant number of respiratory distress patients in the field. The use of certain respiratory interventions is very common, such as oxygen adjuncts, airway adjuncts, and ventilatory adjuncts. Respiratory dysfunctions are typically the result of either an obstruction of air movement, such as something in the way, or changes in the respiratory structures that affect the movement of carbon dioxide and oxygen. Occasionally, both these issues play a role. Respiratory dysfunctions can be further classified as either upper or lower airway problems. Upper airway issues affect the airway structures above the glottic opening, and lower airway disorders affect the structures found from the trachea down into the alveoli. The airway is the path of air flowing to the lungs. The upper airway is comprised of those structures above the level of the glottis, the opening of the trachea or windpipe. Problems of the upper airway reduce the passageway for inhaled air. The classic upper airway problem is obstruction. When the brain is not functioning properly, the muscles and nerves that protect the airway fail. This failure frequently results in an inability to maintain one's own airway. For example, when lying supine, the muscles of the upper airway of a patient with an altered mental status may relax too much and allow the tongue and epiglottis to fall back and cover the glottis. Upper airway problems may happen for any of multiple reasons. For example, the upper airway can also be affected by structural changes, such as swelling in and around the larynx. Conditions such as burns, infection, anaphylaxis, and even direct trauma can cause laryngeal edema and inflammation and result in a rapid decrease in the size of the airway. This slide shows the main structures of the upper airway. In the nasal cavity, air flows past the superior, inferior, and middle turbinates, which are curved bone structures covered with mucous membrane that moisturize and warm the air as it moves through the nose. Air then passes through the oropharynx behind the tongue, down into the laryngopharynx or hypopharynx, past the epiglottis, and into the trachea through the glottal opening. The epiglottis is that flap that closes when we swallow, closing the epiglottis off and preventing food and liquid from entering the trachea. The larynx is the voice box, where the vocal cords vibrate to produce speech. Lower airway dysfunction is often due to resistance changes from bronchoconstrictions resulting from conditions such as asthma and anaphylaxis. Damage to the alveoli can also cause lower airway dysfunction. Examples include congestive heart failure, pulmonary edema, altitude issues, atelectasis or collapse of areas of alveoli, and many other issues. Providing oxygen via a non-rebreather mask to a patient who is breathing adequately but with difficulty will improve the concentration of oxygen in the inspired air. Here's a patient receiving oxygen through a non-rebreather mask with a oxygen reservoir bag. Recognition of respiratory distress supersedes the need to determine its underlying cause. During the primary assessment, the EMT should evaluate both minute ventilation and alveolar ventilation. Minute ventilation is the amount of air moved in and out of the lungs over a minute. Assessment of minute ventilation does not require a full minute, only enough time to estimate if it is sufficient to ensure oxygenation. Assessment considerations include the respiratory rate, the amount of chest wall motion, the patient's speech pattern, body position, and color. Alveolar concentration is the amount of air, or rather, alveolar ventilation is the amount of air reaching the alveoli, the structures where gas exchange occurs and oxygen enters the bloodstream. Assessing alveolar ventilation includes auscultation of breath sounds in the bases, checking pulse oximetry to check for the concentration of dissolved oxygen in the bloodstream, looking for signs of hypoxia in the skin, such as cyanosis, and the patient's mental status, which is often a very strong indicator of adequate or inadequate oxygenation. This is a patient in a classic dyspnea tripod position, where the patient is attempting to improve his airflow by expanding his chest. Respiratory distress findings may include tachypnea, or rapid breathing, the use of accessory muscles to expand the chest wall and rib cage wider, tachycardia, because the heart beats faster to move an inadequate amount of oxygenated blood through the bloodstream, and poor alveolar breath sounds, including wheezes and crackles. In respiratory distress, speech is still possible, if only in short spurts. We characterize this in documentation as 3-word dyspnea, 2-word dyspnea, and so forth. A patient's compensatory mechanisms can be quickly overwhelmed, especially in patients with pre-existing respiratory problems. Here's an emphysema patient demonstrating the classic barrel chest and loss of muscle fat, body fat. Unfortunately, the body's ability to compensate is limited. Some respiratory challenges exceed the body's ability to compensate for them. Over time, compensation simply fails. Respiratory failure occurs when compensation fails. Respiratory failure assessment findings will include absent alveolar lung sounds, cyanosis, poor or absent speech patterns, an altered mental status, usually profoundly decreased, and low pulse oximetry, below 90%. This slide illustrates a patient progressing from respiratory distress to failure and the appropriate adjuncts for each level. Patients with adequate breathing, speaking in full sentences, may only need a non-rebreather mask or a cannula to return their O2 saturation to the appropriate level. With increasing respiratory distress, the patient will become visibly short of breath, may reduce their sentence length to 3 and 4 words, and demonstrate increasing anxiety. This is a key decision-making point. If a patient begins to enter severe respiratory distress, speaking in only 1 or 2 word sentences and becoming very diaphoretic, and severely anxious, we should consider assisted ventilations, such as might be given with the bag valve mask or continuous positive airway pressure, CPAP. If the patient continues to deteriorate, they'll become unconscious and eventually stop breathing. If a patient is beyond mild respiratory distress, we should consider additional adjuncts to improve ventilation and oxygen exchange. In respiratory arrest, there is no spontaneous respiratory effort. This is a dire emergency. The patient will die in minutes without prompt intervention. If the airway is not open, employ techniques to open it. Support the patient's breathing to prevent respiratory failure. Administer high-flow oxygen and evaluate the need for positive pressure ventilation with a bag valve mask. Use only as much pressure as needed to ensure chest rise and fall. Gastric insufflation, pushing air into the stomach, is a risk. Minimize it by using airway adjuncts such as the King airway, delivering ventilation slowly without great force. Consider use of light pressure over the cricoid cartilage to minimize air escaping. To avoid hyperventilation, be careful to ventilate patients at the appropriate rate for a person of their age and size. Here are two rescuers delivering bag valve mask ventilations, one using an appropriate C-clamp to hold the mask tightly against the patient's face, the other using the bag valve mask with both hands, delivering an adequate volume at no more than one breath every 5 seconds in most circumstances. They're using an oxygen reservoir to provide high concentrations of oxygen to the air pulled into the bag before it's pushed into the patient's airway. Continuous positive pressure ventilation, or CPAP, is a new technology in the EMS field. It uses increased airway pressure to help ease the effort of breathing. It also helps with the diffusion of gas in the alveoli. CPAP is in common use for people with snoring problems. Its use in EMS is fairly recent and has been met with considerable success. It's often used to treat acute pulmonary edema. By pressurizing the inside of the alveoli, the fluid of pulmonary edema is prevented from crossing the alveolar membrane. It also helps prevent the collapse of alveoli under the weight of the surrounding edema. CPAP has been proven to rapidly improve acute pulmonary edema in some patients and to prevent the need for intubation. It can also be used to treat other forms of respiratory distress. Keeping the small airways open via this pneumatic splint tends to increase oxygenation and decrease the sensation of difficulty breathing. Keeping the alveoli from collapsing also leads to increased surface area for gas exchange. Importantly, it helps lessen the work of breathing, allowing the patient's compensatory mechanisms to recover. These effects can help a variety of respiratory disorders, including bronchospasm and pneumonia. Indications for CPAP vary from system to system and will be described in the local protocol. CPAP, because the mask covers the patient's entire face, may cause apprehension when patients are not used to it. It's important to use good patient care and rapport development skills in coaching the patient on how to use the device. The patient should be instructed to hold the mask against their face comfortably and to breathe in, allowing the unit's trigger device to flood the airway with positive pressure oxygen. While this may give the patient a feeling of being enclosed, the improvement in their airway will generally allow them to respond quickly. CPAP can cause hypotension or aggravate the blood pressure of people who are on the borderline. Always reassess the patient continually to make sure that the CPAP is providing the expected benefits. Here's a patient wearing a CPAP device. This is used for alert patients who need ventilatory support, not unconscious patients who require respiratory aid. Airway oxygenation and ventilation skills are some of the most important skills the EMT will ever use. Always try to prevent respiratory failure rather than waiting for it to occur in order to be more aggressive in interventions. Ensure that the patient is ventilating and oxygenating prior to developing differentials.